Hello, I'm Dr. Gillian Ray-Barruel with the Avatar Group at Griffith University. We're the Alliance of Vascular Access Teaching and Research Group, and our mission is to make vascular access complications history. Today I'm presenting on the I-Decided tool, a device assessment and decision tool for clinicians caring for patients with intravascular catheters. Did you know that up to 70% of hospital patients will need an intravenous catheter for fluids or medicines during their admission? Unfortunately, up to 69% of these devices have painful complications or stop working before treatment completion, requiring the insertion of a new device. This means patient discomfort, staff time, resources, and increased cost of hospital stay. But IV failure may be preventable with early detection of complications and appropriate action. I believe nurses want to make informed decisions about IV assessment and care, but they're not given point-of-care resources to do so. So I'm presenting the I-Decided tool, which makes it easy to remember the steps of IV assessment. Let's step it through. I stands for identify if the patient has a device. Does the patient have an IV? Has an IV been removed in the past 48 hours? Because did you know the patient can actually get post-infusion phlebitis up to 2 days after the IV comes out? We also know from anecdotal reports, patients have been transferred home, sent home with an IV in situ, which is not excusable. And it's a lack of awareness on the part of the clinician that the patient has an IV. So if you're not sure, ask the patient or check their limbs. Well, if they have a device, do they actually need it? Does the patient need the device? If it hasn't been used in the past 24 hours or has no plans for use in the next 24 hours, consider removal. Perhaps the patient could switch to oral medications. Now, obviously, if the patient is unstable or the patient is on telemetry or has a genuine need for the intravenous catheter, you wouldn't be removing it. But if not, think about it. If it's no longer needed, the device should be removed. The next question is E, effective function. Does the IV still actually work? Does it infuse easily? Does it flush easily? If function is compromised, the device should be removed. Are there any complications at the IV site? Is there any pain, redness, swelling, discharge, hardness, palpable cord, or purulence? Now, these can all be signs of phlebitis or local infection. Swelling and redness can be signs of infiltration. So these are the complications we need to be considering. And if complications occur, the device should be removed. Infection prevention is essential for any invasive device, particularly intravenous catheters because they're going straight into the bloodstream. So it's essential that the clinician performs hand hygiene, scrubs the hub before use and allows it to dry. Always take care when handling IV devices, inserting medications, flushes, infusion and connecting administration sets. And if you observe local infection at the site of the catheter, the device should be removed. It's also important to be aware that if the patient has a bloodstream infection that has no other known source, you should always suspect the intravenous catheter and consider removal. The D stands for dressing and securement. So the dressing needs to be clean, dry and intact. The IV device and administration set needs to be secure. So if there's any problems with dressing and securement, it needs to be addressed because this is a source of potential infection for the patient. If the dressing is soiled or moist, replace it. Get rid of the old dressing, clean the site and replace the dressing. If the lines are flapping around, secure them with a piece of tape, with a bandage, with a securement device. Whatever you have in your site, be sure to use it. So the dressing should be clean, the administration set should be secure. Now, too often we forget to involve the patient in the IV assessment. So the I-Decider tool makes this a priority. We need to evaluate if the patient has any concerns about the IV device and their treatment. And if they have questions, we need to educate the patient about the IV plan, when the IV will likely be removed, what to look for complications. For example, we tell the patient if it's painful or you're concerned about this IV in any way, please speak to one of the staff. It's important that the patient is involved because too often we leave patients out of the discussion, and patients are the ones who know what's going on with their own IV very often. And the final D stands for document your decision. So based on this assessment, I decided to continue the IV but change the dressing or securement, or remove the IV. Now, obviously, you would always consider your local policy and consult with the team or the patient as required at your hospital. But documenting the IV and documenting a decision based on assessment is crucial. So I decided it's really a simple checklist that prompts assessment and decision making. I believe better IV assessment will lead to better clinician decisions and better patient outcomes. So for further information about the I-Decider tool, please contact me. You can find me on email, Twitter or LinkedIn. And I'm with the Avatar Group at Griffith University. Thank you.